An interesting topic that I think we can all agree sounds interesting, looks interesting, but again, the question is, how practical is it? I'm having problems. I cannot, well, let me try. There we are. So basically what I'd like to do in the next 15 minutes or so are to revisit some of the benefits of MRAs in people with CKD and heart disease. We obviously know that many people with CKD also have a lot of CVD burden, and obviously vice versa. We'll also talk a little bit about some of the problems of hyperkalemia and look at some of the newer opportunities in this regard and discuss some of the management challenges with it. There's a lot of reason to target aldosterone in any type of tissue-based disease process that involves fibrosis. We've certainly seen a lot of opportunity with blood vessels, the heart, and now we're paying a lot more attention to the kidneys and obviously to prevent stroke in the brain. The consistency of benefit in heart failure is impressive, and some would even argue that the TopCat program would have been positive had they been a little bit more careful about selecting sites and some of the differential observations from around the world. Certainly we have very consistent benefits with ACEs and ARBs with regard to outcome, about a 20% relative risk reduction benefit. But of course the question is, can we improve upon that? And in people with heart failure, the ROUSE study was certainly one of the most important steps in the right direction, which clearly demonstrated the utility of adding an MRA on top of standard of care. Likewise, the subsequent EPPHASIS study was done, which again compared adding an MRA to standard of care versus placebo and showed very important benefits. So obviously, moving ahead now with the EMPHASIS study, looking a little bit earlier in the disease process, again, demonstrating important clinical utility. The important thing to remember about all of these studies is that there was an effort to exclude people with advanced kidney problems and to look at people with better kidney function. But the reality is there is not a lot of good prospective randomized controlled trials in people with CKD. Because in large part in all the big heart failure studies, they were systematically excluded because of concerns about potassium handling. But the experimental studies are very encouraging. We certainly have a number of small studies showing the utility of an anti-proteinuric effect with MRA, which is not always associated with a robust blood pressure change with it as well. Probably the best study to look at this was a very nice double-blind randomized controlled trial that Bob Toto's group did with diabetic nephropathy, where people were on 80 milligrams of lisinopril and then randomized to stay on to go on to placebo, losartan, or low-dose spironolactone for the period of a year. They saw a much better reduction in proteinuria with spironolactone, as you can see here, even compared to adding losartan. It's important to note that the losartan group had a potassium level go up by about 0.4. The spironolactone group, it went up by about 0.7. And that has certainly been a limiting feature in some of the clinical trials. But what was impressive was the fact that you had this additional antiproteinuric effect, which appeared independent of blood pressure change. But the real problem, let's agree, are the problems of hyperkalemia. And certainly it's more substantial in the real world than it is in clinical trials, and we're all aware of the hospitalization rates in Canada soon after the ROUSE trial was published, when everybody started adding MRA to their patients with heart failure. The issue is primarily related to CKD, and I suspect the fact that this has really limited our efforts to really focus on using these drugs, especially in people with diabetic kidney disease, because of the greater prevalence of problems with hyperkalemia, despite the epidemiology showing you just how much more problems there are with CKD and heart failure in this type of population. We also know, too, that these people have a large mortality burden as well, as you have declining kidney function in people with CHF. So there has to be some balance between what we see here and what we saw on the previous slides, indicating concerns about hyperkalemia and yet not taking advantage of the benefit in a high-risk population group. Again, the conundrum is shown here: declining kidney function, increasing rates of hyperkalemia in the Ephesus study. Yet, we similar have data from the RALS study showing even if you were hyperkalemic, the risk of death was improved if you were on MRA compared to placebo. But we have to face this battle, and that is, epidemiologically speaking, people with higher serum potassiums, in a sense, are at risk for perturbations which could lead to abrupt changes in potassium and potential associated arrhythmias. The treatment options for acute treatment we're all familiar with. The real problem is chronic therapy. And really, what most people have done is they've done the charade of a low potassium diet, which no one pays attention to. They stop the RAS blockers, that's most common. And certainly in Europe they use calcium resonium, or in the US they use K-exolate, which is basically dreadful tasting, and patients often won't be compliant with it. So there are a lot of long-term limitation strategies that we have available to us today. None of them really work well. Certainly one can amplify diuretics, even give sodium in the form of bicarbonate with diuretics to help. But often that can be problematic, particularly in people with more advanced kidney disease and heart failure. And again, reducing dietary potassium is very unlikely to be beneficial chronically. There are some future opportunities that I'd like to finish my conversation with you with. Two of the newer potassium binders, patiromer, are already available. CS9 is coming soon. There's a new non-steroidal mineralocorticoid receptor which is now being studied in 2 large outcome trials called finerenone, which may also be an opportunity. And then I'll speak a little bit about our own work studying MRA as part of a strategy to regress atherosclerosis in people with diabetic kidney disease. The first thing I'll mention is patiromer. There are good studies now going out a year showing that it can successfully and safely lower serum potassium levels in people on RAS inhibitors with chronic kidney disease, with or without heart failure. Our own work has shown basically that as you lower aldosterone levels, as you lower potassium levels with patiromer, you also see a concomitant reduction in aldosterone levels. This could be potentially beneficial in people with chronic kidney disease, with or without heart failure. We've also seen intercurrent changes and reduction in blood pressure. Now, whether that's related to reductions in aldosterone levels or perhaps the patiromer is binding to sodium, we just don't know. More studies need to be done to examine this phenomenon. CS9 is another non-selective potassium trap that's going to be coming out soon in its final phases of testing, which also may be an opportunity as well. It, too, has demonstrated utility in safe and effective lowering of serum potassium levels. Its long-term studies are about to be completed very soon. Finerenone is a non-steroidal mineralocorticoid receptor blocker. There was a very nice study called ARCH-DN, which was published a couple of years ago, which was a randomized controlled trial to evaluate the antiproteinuric effect of this drug on top of RAS inhibition in people with diabetes and albuminuria. The UACR at 90 days was compared to baseline, and there was a great deal of attention towards the amount of problems of hyperkalemia. Please note the age was actually, to me, looking younger every passing year. They were quite young at age 64. The GFR was well preserved, and the baseline potassium levels were 4.3. You can see the reductions in proteinuria occurring in a dose-dependent fashion with the higher doses that were being employed here. And these are rather substantial reductions. You can see by about 50% down here, so with the higher doses you're looking at about 35%. Interestingly, there was not much of a change in GFR as you follow across, and interestingly, not much of a change in the serum potassium level. Again, not much change, which again is an encouraging opportunity that maybe there's something different here with its mechanism that may be helpful in reducing proteinuria and maybe with kidney disease, but avoiding problems of serum potassium. Lastly, I'll finish with a project that we're working on. You can see the acronym here. You can't do a good clinical trial without an outstanding acronym. This is a study that was funded by the National Heart, Lung, and Blood Institute. And basically what we're doing is we're going to randomize, we already started the study now, we've been working on it for about 8 months. We're going to randomize 135 patients with established diabetic nephropathy and known atherosclerotic events to a double-blind randomized placebo-controlled trial. They all have to have type 2 diabetes, reduced GFR, and have clinical proteinuria, and they will receive 25 milligrams of spironolactone versus placebo. We're specifically focusing on co-primary endpoints of percent change in atheroma volume as determined by MRI on their thoracic aorta, as well as LV mass regression, also determined with MRI. And then we're also going to be doing deep phenotyping to see if there may be more understandings about the effect of MR blockade in people with diabetic nephropathy. We're also looking at microRNAs, which regulate inflammation as predictors of disease progression and response. And let's all agree we need better biomeasures and imaging to understand more about CKD intervention plans and how to predict response. We're also looking at monocyte inflammation factors as well. And this is basically what it looks like. A 4-week run-in, 2 weeks on placebo. They get imaged and all the biomarkers done, escalate the dose, and then wait a year, and then re-image, retest, and follow them accordingly. We're going to try to keep people out of the study who have poorly controlled diabetes, and we want people with reduced GFR but proteinuria and have atherosclerotic events. They all have to be on ACEs and ARBs. So putting this into perspective, I think there is a substantial opportunity here to further explore the utility of MRA in people with chronic kidney disease. They've certainly demonstrated a very powerful benefit in heart failure. We know that most people with heart failure have CKD or are going to develop CKD, but the biggest conundrum we have is the clinical risk of hyperkalemia. And obviously this leads to a cessation of existing RAS antagonism without even starting an MRA. CKD is also a growing problem in patients with heart failure that makes hyperkalemia a daily concern in practice. And there's growing evidence that hyperkalemia is associated with mortality, which is obviously the major balancing effort we have. Current treatment options we have today are focused on acute management. I think we clearly need chronic therapies as part of our effort in order to have a better long-term strategy for dealing with chronic kidney disease and certainly also with heart failure. And I think that's going to be important. And I don't believe we can rely on dietary interventions or reductions in our RAS inhibition. I think obviously that's not the best thing we can do for our patients, so we do need to step up. And hopefully some of these studies will be important in this regard to provide new opportunity. I think the 2 new potassium binding therapies offer great promise. I'm very interested in the 2 large outcome studies now being done with finerenone, and of course I'm very intrigued with our imaging and biomarker effort in using spironolactone in people with established diabetic nephropathy as a means of providing more information in this regard. Thank you very much for your attention.
Thank you very much, Professor Weir. Are there any questions or comments? I will I will kick off by asking, you know that ACE and ARB combination is found to be detrimental in many studies. Do you see any future combining of MRI with an ACE inhibitor or ARB with hard outcomes for both cardiac and renal?
Well, again,
and what's the difference?
I do think that there is a sizable difference between adding an ACE and an ARB or adding an MRA to an ACE and an ARB. I mean, mechanistically, they're different, and there may be more that we don't even know yet about the mechanism of action with MRA that is still not yet fully elucidated. From a clinical standpoint, adding MRA to established ACE, beta blocker, diuretic therapy in heart failure has not proven to be a clinical problem. And let's agree that we haven't done enough work yet in CKD to really know. Hopefully we'll have more data and more studies will be done in this regard. I think the biggest problem with ACE and ARB is, number one, it didn't show any incremental benefit on either cardiovascular or renal outcomes for that measure. And number two, it was associated with more AKI and more hyperkalemia. So again, there's no upside, there's some downside, so why bother? I think it's going to be a different picture with MRA in well-done clinical trials.
Is the risk for hyperkalemia lower for patients on dialysis without residual kidney disease, or is there also an impact on gastrointestinal potassium handling?
Great question about whether or not there's a lower risk of hyperkalemia in people on MRA. You know, there are two outcome studies now being done to address that issue. And I think until those are done, we do not know. My clinical suspicion, having given MRA to dialysis patients over the years, is that there's not that much of a change. I don't think anecdotally that there's a major concern. But the studies are being done, and who knows, maybe they'll be done in time for this meeting next year. I believe both of them are being done in Europe, so they're European trials, and so I think that will be very helpful for us. If it's a step up, I think it'll change our standard of care in our patients in that regard.
Any questions? Okay, thank you very much, Professor Weir.